Good evening and welcome to APPNA Zoom webinar series part 3, Ask the Experts. This is an initiative by the APPNA to help our local communities to give an opportunity to them to ask questions to our expert panelists. COVID-19, the latest number in United States, confirmed cases 740,746, confirmed death 39,158. This is today's figure. And worldwide, 2.35 million people are affected, and the death worldwide was 161,402. APPNA has stepped up to the plate and has been helping fellow physicians and local communities both here in USA and in Pakistan by providing PPE, and has joined hands with food pantries and NGOs to help people in need in food assistance. For this reason, APPNA has also arranged a telethon on April 26th, which is a Sunday, from 5 to 7 p.m. And we hope that all of you will join us on the telethon as well. We have 3 guests today. Dr. Aisha Zafar, who is the chair Social Welfare Disasters Relief Committee, and Dr. Sajid Chaudhry, who is the chair task force which was created for coronavirus. And we also have Dr. Asif Rahman, who's a cardiologist, and he's a chair board of trustees of APPNA. They will give us an update on the efforts which APPNA has taken so far with regards to the relief efforts. The 3 panelists today are Dr. Rashid Chodani. He is the professor of epidemiology, University of Nebraska Medical Center, vice president, medical affairs, Care Life, Chief Scientific Officer, Washington Vascular Services. He's a senior scientist, IEM Incorporated, senior fellow, Potomac Institute for Policy Studies. Dr. Rizwan Khalid, who's an associate professor of medicine and cardiology, advanced cardiac electrophysiology and disease therapy, interventional cardiology and vascular medicine, and he's also president-elect of APPNA. Our third panelist today is Dr. Arif Mumtaz. He's an associate professor of medicine, New York Medical College, Westchester. And the special thing about our guest, Dr. Arif Mumtaz, is that he is recovering from COVID-19, and we have invited him, and he is going to share his personal experience with us. So without further ado, I'm going to ask first Dr. Aisha Zafar and then Dr. Sajid Chaudhry, followed by Dr. Asif Rahman, to give us some brief report on the efforts which APPNA is taking for COVID-19. Dr. Aisha Zafar.
Assalamu alaikum ji. So we have actually, mashallah, had an excellent response from our donors. In the past week, we have transferred about $90,000 worth of food, which has gone to Pakistan. In US, we are basically working with the APPNA relief pantries. We have also started working with the local food pantries. In any area, if someone wants to contribute to that, mostly we are matching $2,000 for every $5,000 that are raised. So locally, we have given about $55,000 for that reason. As far as the PP is concerned, Dr. Asif Rahman has been very involved with that. We have a very good volunteer on ground who is actually a member of the Social Welfare Committee. And the PP, which as we've ordered PP worth $100,000, most of this will be coming to USA, and we are sending about $18,000 worth, which will be going.
Thank you very much. Dr. Sajid Chaudhry.
Assalamu alaikum. As Dr. Aisha mentioned, we have started about 3 or 4 weeks ago, and mashallah, we have raised over $550,000. An order for worth of $100,000 was placed for USA for the PPEs. We ordered 10,000 of N95 masks, 25,000 of KN95 masks, 10,000 of face shields, and 10,000 of
Protective gowns.
Protective gown.
Thank you, Aisha. We have already shipped to about 8 hospitals in New York and 95 masks and face shields. Our chapters contributed with us, and APPNA matched their funds, and we have already passed our PPEs towards our chapters to provide in the local hospitals. Unfortunately, we are not getting as much as N95 mask as expected because of some delay in China, and there's some problem with getting N95 mask from China. We're hoping we will get more N95 masks by next week, and we will ship to our all the chapters. We are also participating in a program with the state of Kentucky, where 7,000 KN95 masks will be distributed to frontline workers in EMS, firefighters, police department, and will be distributed through the state of Kentucky. And our APPNA, lifetime member of APPNA, Dr. Baba Chima, is coordinating that effort. We have also started a matching fund program with our members and local chapters to provide hot meal to local hospital staff who are taking care of COVID-19 patients, to our EMS workers, volunteers, to our firefighters and policemen who are dealing with the public at the front. Once again, I would like to thank all our membership. They have stepped up. Would like to thank my executive committee, especially Dr. Harun Durrani and Dr. Rizwan Khalid, who have helped us throughout the efforts with all the logistics through the office. I would also like to thank our president, Dr. Naeed Usmani, for her contribution and cooperation with the Social Welfare Disaster Relief Committee as well as the COVID-19 task force. I would like also mention support provided by Chairman BOT, Dr. Asif Rahman, and his personal involvement in the managing and distribution of the PPE in our warehouse in New York. Once again, I would like to thank all our chapter presidents who contributed and are working at their local level and participating in APPNA relief efforts. Thank you very much.
Thank you very much, Sajid. Dr. Asif Rahman, Chair, Board of Trustees.
Good afternoon. Assalamu alaikum. First of all, I want to thank Harun Durrani and Rizwan Khalid, as well as rest of the executive committee for arranging all this, so we should know, at least we can let people as well as APPNA what we are dealing. I also want to thank Aisha Zafar and Sajid Chaudhry, Chair Social Welfare and Chair Task Committee, that what an awesome job they are doing. Historically, if we look at APPNA's history, I have seen second time that APPNA is so motivated in social welfare work. First time was in 2005 earthquake, and both Aisha and Sajid were involved at that time. That was the first time when all the members in community were together, raising funds and helping people in Kashmir area, particularly in earthquake zone. Now this, we are dealing at a different capacity. We are dealing with pandemic. We are dealing all over the world, but specifically what is happening in United States and in Pakistan. Thank you for hearing good news is coming out of Pakistan, that they are not as affected as US. But here, living in New York, I am an invasive cardiologist. We have stopped doing all invasive elective procedures unless there is emergency. I just came back after finishing emergency. But we are also on the front line seeing all heart-related patients, particularly when they are coming with the coronavirus in emergency room. So I can tell you that for last few weeks, it was just unbelievable what we have seen. Patient coming in, dying. Luckily, in my hospital, we have all the equipments are available, but it is rationed. I mean, everyone comes in the morning, they sign in, and they get the equipment. But rest of the few hospitals in Brooklyn and in other areas of New York, there is some deficiency. People are short of personal protective equipment and all of the face mask and 95. So that's where our organization is helping. I think Social Welfare Task Force designated person, Shahzad Iqbal, I want to commend him that how great job he's doing. And I am also trying to be there as much as I can. I think it will not end anytime soon. We will have lot of things happening even after that peak, and particularly which I am concerned about our Pakistani community in New York and in other affected areas, people who are on daily wages or people who were working in small jobs and now they are out of the job. They don't have a salary, they have a rent issue, and I am glad that we have collaborated with ISNA, and they have I have witnessed at least once or twice occasion that I went there where they were providing the food, particularly in developed areas, people who are in a need. But I think that work, providing groceries, providing food, everywhere where we can in the needy people, but we should also focus towards our own community, because I can see there is a dire need of that in this.
Yeah.
And I think I want to thank everyone for taking their time on Sunday afternoon to join. And please stay tuned, stay engaged, and try to help communities and Pakistani communities in your own areas and anywhere else you can. Thank you.
Thank you very much. It is really very heartening to see how the chapters and the alumni of APPNA has stepped up, and the way they are contributing, the way they are providing support to the task force and the Social Welfare Disaster Relief Committee. It is really commending. And this is, as Asif Rahman said, that this is not going to be over soon. We are going to continuously need more support from our communities. And I just want to remind our viewers again that we are going to have a telethon on April 26th, which is a Sunday, 5 to 7 p.m. on TV1 channel. We will have special guests. We will have motivational speakers and others. So please join us for fundraising as we continue to do that. And we need to raise as many funds as possible. So having said that, I want to thank all our guests. We move to the second portion of the program, which is our experts. And I'm going to ask each of our experts to give an opening statement, starting with Dr. Rashid Chodani. Okay, I think it's 5 o'clock. We continue to do that.
Alaikum. First of all, thank you for all the work that you guys are doing at APPNA. It's really commendable. It is desperately needed for Pakistan. And what APPNA is doing for the physicians and healthcare workers, as well as the rest of the Pakistani community in the United States of America. We all need to understand and appreciate that this disease is a critical issue. It was mentioned that we have 38,000 deaths. Well, the numbers just came to me that today the death toll has gone up to 40,000. So this is a problem, as has been mentioned before, is not going away soon. And we've got to make sure that we are dealing with everything that we have in our toolbox to deal with it. About 2 months ago, we started our efforts in this regard, working on specifically a very controversial issue and taking lead in that and starting looking at antibody testing. And we initiated that process. And now, fortunately, the entire country is going to be using that particular methodology. And the kit that we were using was not something from China. It was manufactured in the US. Unfortunately, nobody, and it was a limited quantity, but we did some testing. We validated it. We have now at our center, we've done about 500, screened about 500 healthcare workers as well as individuals. And we have some very good results coming out of it. So the critical thing to do over here, and that's what I've been talking about, is how are we going to open our nation back and get back to normalcy. It is not going to be easy. There is an administrative plan that I have worked with colleagues on that talks about 3 different phases and how 3 different phases are going to work. Fortunately, that plan is a fluid plan, that can be implemented across the states in any particular way that they want to implement it, depending upon what they are seeing in terms of the disease. Now, as we all know, this virus is in control. We are unfortunately not in control. So we have to make sure that we appreciate the epidemiology, we appreciate the incidence and prevalence of the disease, and then we make decisions based on that. And then again, it is critical that everybody is cautious and takes the right precautions because it's indiscriminatory in terms of who it affects. So it can affect an individual and they will not have the symptoms. They will be healthy as anything, and they'll be transmitting the disease. And that is the transmission that we want to stop. But having said that, I will stop here and let the other speakers introduce themselves. The only thing that I'd like to mention is that my life has been spent as an infectious disease epidemiologist, and that is what I was trained for at Hopkins, and that's what I've been doing for the last 20 years, having gone to various outbreaks and other disaster-related issues, and extremely passionate about this thing. And I'm extremely thankful to APPNA, and being a member of APPNA, I'm extremely thankful that I've been asked to come and talk about it.
Thank you very much. Rizwan, Dr. Rizwan Khalid.
Assalamu alaikum, everybody that's listening. सबसे पहले तो मैं शुक्रगुजार हूँ APPNA की EC का, and I'm very thankful to Haroon for doing this community awareness webinar. This is our third webinar. We've been doing it every week, and we have been taking questions directly from the public as well as our non-APPNA member colleagues as well. I think this is a great service that APPNA is providing, and we try to answer your questions in the best possible way that we can. As a president-elect of APPNA, most of the things that APPNA has already done have been mentioned by Dr. Aisha Zafar and Dr. Sajid Chaudhry and the chair BOT, Dr. Asif Rahman. We're very thankful. I cannot thank them enough. I thank them every day. Dr. Sajid Chaudhry, Dr. Aisha Zafar and their team have done a phenomenal job. As Dr. Asif Rahman mentioned, this vigor, this spirit, this enthusiasm that we have seen, it reminds me of October 2005, when we all got together and took the challenge of when the earthquake happened in northern Pakistan and Azad Kashmir. We took that challenge head on. So I'm very thankful to Dr. Sajid Chaudhry and Dr. Aisha Zafar and the team members who have worked, put in a lot of long hours in this, and results are showing. Our membership has supported us, the chapters have supported us, all the alumni have supported. And not only have we worked in the US, but we have worked in all major parts of Pakistan as well, in food pantries, protective equipment, webinars. We are also doing this clinical webinars every night since 31st of March. And we share educational experiences with our colleagues in both Canada, Pakistan, and the US. And obviously, we are going to do a telethon next weekend. And I would appreciate if everybody joins us and helps us in raising more funds. My background is cardiology. I do both interventional and electrophysiology. I am directly taking care of patients with cardiac manifestations of COVID-19. We have also written a review paper on cardiac manifestations of COVID-19. I'll be happy to answer any cardiac related questions or any other questions that the moderator feels that I should answer. Again, thank you very much to all the panelists, to all our guests, and all our listeners. Thank you very much.
Thank you very much, Rizwan. Dr. Arif Mumtaz.
Yes, thank you. Dear friends and colleagues, Assalamu alaikum. I want to introduce myself as an internist working in the New York area as an internist for the last 27 years. Actually, I want to start by apologizing for being the underdressed one on the panel. I'm still in quarantine and I don't have access to my coats and jackets and ties. So
That's
as a professional as a person who spent all my professional life in the New York State area, I've been working in an academic hospital just outside New York City, and I supervise residents and interns directly in their training. As you know, New York State became the epicenter of this COVID epidemic in early March. And since then, we have been trying to prepare ourselves for this. And still, at the end of it, when the actual avalanche of patients hit, we realized we were quite unprepared. The first case in New York City actually was not in New York State, was not in New York City, but was in New Rochelle, which is in Westchester County, not far from the place where I work. So this all started in the beginning of March. And since we got our first patient, we very quickly, the number of patients accelerated, and we were very quickly overrun by the number of patients that we had, just like any other city in the hospital. And during this time, along with all the other faculty and with the residents, we experienced patient suffering, death, destruction of the level that none of us had ever seen. So as far as COVID goes, I'm not an expert on the topic, but being a physician who was on the front line and has been doing this for many weeks, and then eventually became a healing victim of the disease itself, I'd be happy to share whatever experience I can with you. Thank you.
Thank you. Thank you very much, Dr. Arif Mumtaz. I'm really thankful to you that you agreed to share with our viewers your experience, your personal experience. I mean, being on the front line is one thing, and then getting positive, and then being in quarantine and agreeing to come on in our webinar. I really thank you for that. I think I'm going to start with you, Arif.
Yes.
So would you like to share your personal experience from developing symptoms early on to the current stage you are at? How it was, how do you feel, and how your experience has been?
Well, the symptoms, as we all know, is there's a myriad of symptoms that everyone gets. It's usually some sort of syndrome which resembles having a cold. It can be having a very mild kind of cold, or it can be having very bad cold symptoms. In my case, it started with one day being at work and then suddenly feeling very fatigued and tired to the extent that I just couldn't function, and first attributed it to being working long hours, but then realized that it was a little more than that. I found a place in the hospital where I could just lie down on the ground, and I just decided to sleep for a little bit, but I ended up sleeping for most of the day. And when I woke up, I saw that there were multiple messages and texts on my phone that I just slept through. I just went home and spent the night, separated myself from the family, and then the next day went back and got tested and was found to be positive. And then soon after that, I started developing high-grade fevers, body aches, and to the extent that at night I started having hallucinations also. The nighttime was the time which was the toughest, because that's when you're separated from reality the most. You are resting in the dark and you're alone, and the line between reality and imagination becomes very blurred. So that was a hard time in the beginning. The days were better. I have been in quarantine since then, and the worst time I would say was from the first day to the 6th or 7th day. Then after that, the fever started to break, and I started to gradually feel better. I am still in quarantine right now. Today is day 13. I plan to do another day. But overall, except for a non-upper respiratory cough, I think I'm feeling much better right now.
Incredible, incredible story. And we are very happy that you're almost recovered, and that you have shared with all the experience with us. Thank you very much. My next question is to Dr. Rashid Jordani. This is like he's a professor of epidemiology, and I think he's the best person to ask this question. We hear about this flattening of the curve. Can you just simply explain us what does that mean, flattening of the curve, And does that mean that once the curve has flattened, is that the end of it, or we are going to keep on seeing uh, this COVID-19?
So the flattening of the curve is something that we want to do in order to make sure that we have enough capability and capacity within our hospitals to deal with the surge. The number of cases, yes, will decrease if we do, if we have the measures, the quarantining measures, because if we quarantine people, they're not going to be transmitting the disease to others. That means that you will have a less burden of the disease. But the flattening specifically is useful to make sure that the hospitals have enough beds, enough intensive care units, and enough ventilators to take care of patients. There are going to be patients that will develop the disease, that will require hospitalization, that will require intensive care unit admissions after you have flattened the curve. Flattening the curve doesn't mean anything doesn't mean that the disease is gone. The disease is gone when the curve starts coming down and you see a downward trend, and then it kind of goes all the way to the bottom. So that takes a long time. Now, one of the things that we have also appreciated with this disease, whether we look at Australia, which was having summer when we were having winter, and that the disease was still propagating over there. And we've also seen in other places around the world where the disease essentially went down, but still kept some sort of activity, a very minor, tiny, activity at the bottom, and still had cases. China is still having cases. It's not that China is not having any cases. Other countries are having cases, but very small numbers. And those are the numbers that we can deal with. Unless and until we have vaccination, therapeutics, a very strong therapeutic, we really don't have a control over this disease. And we just don't have the control in terms of herd immunity. So that's going to take a while to be able to get to that point. So all of this doesn't mean that the disease is going to go away. Flattening of the curve just means that we are now controlling it a bit, and then at some point it is going to start declining.
Declining. Thank you very much. Thank you very much. My next question is to Rizwan. I have heard that ACE inhibitors may worsen COVID-19. Is this true? If it is true, then should I stop taking that medicine? We can't hear you. You too.
Yes, that's an excellent question, and Dr. Asif Rahman is one of my colleague cardiologists as well, and he can jump in anytime as well, and we can benefit from his experience as well. The COVID-19 actually gets through interest. It's a receptor at the surface of various cells, which are one of them is similar to the ACE inhibitor receptor, which the ACE inhibitor, when it attaches to cells, it causes an increase, extra expression of these receptors. So basically, the question or the theory was whether if somebody is on an ACE inhibitor, will that worsen the likelihood of them having COVID-19 infection? We do not have enough information to say yes or no. However, all the major societies, including the European Society as well as the American societies, do not recommend stopping ACE inhibitors or angiotensin receptor blockers in this situation, whether you have COVID-19 or you do not have COVID-19. You should continue taking your ACE inhibitors as recommended by your physicians. Now, there are patients with COVID-19 that develop hemodynamic compromise. They may be hypotensive. Now, the treatment at that point in time is just like any other hypotensive patients in which we will stop. That's my daughter. I'm sorry.
We have a guest.
So just like any other patient, when the patient is hypotensive, in the ICU, we stop their ACE inhibitors and antihypertensive agents. So in that situation, the treating physician has to make a decision, but not making a decision just based on that it works on a receptor. That is, so I would not recommend in the general population. Thank you.
Okay, thank you. Asif, you want to add anything?
Yeah, only one thing I want to add. I think Rizwan was very much right that unless patient is on, we will not stop it. But we have also, Rizwan, noticed that most of these patients with coronavirus, when they get sick, they end up into multi-organ failure, and I have seen a lot of acute renal failure, and their creatinine is very high. At that time, if someone is on, then we have to stop anyhow. But otherwise, I think Rizwan was right. Thank you.
Very good. Thank you.
Can I ask a question to Rizwan and Asif?
Sure, sure.
So some of the literature is suggesting that there are two ACE inhibitors, right? 1 and 2, and coronavirus specifically attaches to one of them, not both of them, and the drug that you're using actually works on the other one. Do you guys want to elaborate on that or express some thoughts on that particular thing?
Yes, and you're absolutely right. There are two ACE receptors, and one of the ACE inhibitors, they work on a different receptor. Yes, but again, as Dr. Chitani, as you know, there is no study that has demonstrated that we should still stop ACE inhibitor.
I'm absolutely not saying it. I'm actually saying that that coronavirus attaches to a different ACE inhibitor versus the drug itself. So I feel very comfortable from the studies that are out there and the literature that's out there that in normal circumstances you can continue to use the ACE inhibitors as you're using. But yes, when you are in an intensive care unit and when you have multi-organ failure, then you have to consider taking them off. So,
yeah, thank you.
That's correct. I think that's correct. If the patient is in acute renal failure, you're going to stop both ACE inhibitors and second receptors ARBs.
Which we will do anyways, even if the patient did not have COVID-19 and they presented with acute kidney injury, we would have done that anyways.
Very good. Very good. Thank you very much, gentlemen. We have an attendee, Nadeem Khan, is asking a question to Dr. Arif Mumtaz. What was the scariest part for you while going through the recovery?
I think, assuming that he's talking about the symptoms, I think it was when you had the high grade fever and that when you became disoriented along with that. Because the problem is that you are in quarantine, you're away from your family, you don't have much help around you, and it becomes very difficult to distinguish between reality and dreams. A lot of the times I would dream that I had a certain symptom, and then I would wake up and then I would think that I was having the symptom, and then I would become all confused whether it was real or whether it was not. And then trying to reorient yourself on your own while dealing with this was the most disconcerting and most scary part of all of it.
Thank you. My next question is to Dr. Chitani. Why certain states are hit worse than the others? Some states have very low number.
It's a very good question and a very interesting observation. So how a virus reacts and spreads is that it doesn't spread all over the country at the same time. It spreads in densely populated areas much faster than in non-densely populated areas. Not only that, the virus has to reach into a territory for it to then express itself and contaminate others, and people get sick. Some of the states, after observing what was going on in New York, implemented very quick, quarantine measures, very strict restrictions. The school closures in the country at different levels was at different times. So that is one of the most important things that we have to consider. The virus, once it's out, it is out. There's no question about it. So it's not that it's not going to spread in those particular areas, but if you are going to put the restrictions that you have implemented, you can slow down the spread of the virus. Now, just to think about it, if I was infectious, right, and if I went out every single day, I had a potential of infecting 2 to 3 people minimum every single day, every time I was out, or maybe more. We don't know exactly, but we are saying 2 to 3 people in a day. So here is if now I'm quarantined as a good doctor has been quarantined for 14 days now, right? He has kind of stopped the spread of the infection. Now, he identified the disease early, fortunately, but one of the critical things to observe is the latest data that is coming out. One is infectious 1 week before you develop symptoms. So that is another caveat that we've got to take into consideration. So you've got to be extremely vigilant. And that's why one of the critical things to do is to try and make sure that we do mass screenings and find out who's infectious and who's not.
Very good. Very good. So another question regarding cardiology. I heard that hydroxychloroquine has adverse effect. Is there any role in treating COVID-19, and is there any optimal timing versus early on versus late in the disease process? Rizwan?
So with Dr. Durrani, with your permission, I would not talk about when to give hydroxychloroquine, whether you should give it prophylaxis or not. How about I talk about the concern with hydroxychloroquine and QTC prolongation.
Okay.
That is something that everybody, when there was this question about giving hydroxychloroquine for prophylaxis to the masses, that was one of the questions that was raised, that hydroxychloroquine, it's a sodium channel blocker. Not only it works on the sodium channel, it also works on the, there's a potassium rectified current, inward potassium rectified current, which also is blocked by hydroxychloroquine. It is very similar to the chloroquine that is given as an anti-malarial. And both of them have some antiarrhythmic effects, like a class 1 antiarrhythmic effects. So one of the things that was concerning to many of the ICU intensivists and infectious disease was this: if you give hydroxychloroquine with azithromycin, should there be QTC monitoring? Is there a risk of torsade or polymorphic VT? So the thing is that what we are doing, like I was doing on a patient today when I rounded, that we do a daily monitoring of EKGs. And if your QTC is more than 500 milliseconds, you have to stop hydroxychloroquine. At that particular time, the risk of torsade goes high up if your QTC is over 500 milliseconds. However, if you do it for the first 4 days and your QTC does not go up, is not prolonged, then you can continue doing the combo therapy of hydroxychloroquine and azithromycin. And on the patients that I have, we stop it at day 4 if there is no prolongation of QTC. One of the things that I will add to, many of the attendees are also physicians, although this is also for the community as well, is that I have seen a significant sinus node inhibitory effect. So most of the patients that have that go into ARDS, they will develop sinus bradycardia. So the SA node inhibition is also something that we see in addition to QT prolongation. And we all know that there is a QTC prolongation with bradycardia, which is bradycardia dependent as well. So the question that should we stop hydroxychloroquine just from a cardiac perspective? No. If it is needed, it is beneficial, we should start it, but we just have to do QTC monitoring. If Asif wants to add something, I'll be happy to hear.
No, I think electrophysiology is your specialty. You probably explained well. My only thing which I'm a little bit cautious, that if someone has structural heart disease, if they already have coronary artery disease and congestive heart failure, at that time we are cautious, but the parameter is, as Rizwan said, is QT interval needs to be monitored. And I have seen patients, there are a lot of patients they are on, and very rarely we have to stop because QT is prolonging. I think when someone is in bad condition, when you know the outcome is worse, then you try to do everything what you can, and including hydrochloroquine use.
Thank you very much. My next question is to Arif, Dr. Arif Mumtaz. The question is that Obviously, when you were having interaction with your COVID-19 patient, you were using all the precautions, and you still got infected with that. So, is there anything which you think that you will do differently now in order to protect yourself? Or what are your recommendations that physicians in the front line should basically do in these situations?
Well, yes, I think it's a high risk situation when you're working with directly with COVID patients. You are at risk of getting the disease more than anyone else. The obvious things that you can do or you should do is proper use of the PPE, practice putting them on, practice taking them off, because it's a whole process. Make yourself comfortable with it, take your time doing it. But having said that, you're still exposed at a lot of situations where there's just too much work going on, or there's a state of a condition of an emergency and things get compromised. So you do your best there. But besides the PPE, I think there are a lot of other things that physicians should be doing when they're working with these high risk patients. Because mostly we are thinking of our patients, thinking of our work. And I think that one of the important things which we should do is think of the eventuality when you fall sick yourself, that are you prepared for that? And that was something from my personal experience I saw that I wasn't at multiple levels. Because one of the things that you got to think of is that how are you going to deal with this, and how is your family going to deal with this? So the first thing you have to do is to think of quarantining yourself. So you have to look at your home situation. You have to discuss it with your family, with your spouse, that where are you going to quarantine yourself and how is that going to work? Because we take it for granted that everyone knows what quarantine means and what it entails, but that's actually not the case. While I was in isolation in the beginning, I would have the door suddenly open and one of the children come in with something for me to eat or to drink, or holding a phone saying that so-and-so is calling and they want to talk to you. And so I had to explain to them, or other people helped me with that by calling and explaining that this means that now you're not sharing things anymore. All the things in the room are mine and all the things outside the room are not mine. So we have to keep it in that way. So that conversation, I think, should happen beforehand. You have to identify a place in your house where you're going to do this. A lot of people go with rooms in the basement, which I think is not a good idea, because this is going to be for a minimum of 7 days and can go on to 2 weeks, as it did in my case also. So I picked a room which was kind of like a sunroom. So it has a lot of windows in it. So I'm not cooped up in a basement room with no natural light. I get sunlight also. I can see outside. I can see what's going on in the world. And I have a little room where I can walk also. So I think that was a better option. Besides that, I think you got to be ready with your symptoms. You got to have a plan in that if things go worse, then what are you going to do? Most of our physicians, once they get sick, they're not going to have mild symptoms or very severe symptoms. They're going to be kind of in the middle where the symptoms are kind of moderate. But from there, they're either going to get better or they're not going to get better. So we should have that ability to recognize when we're not getting better and we need further help. In my case, I was fortunate. I worked in a place where I had a lot of colleagues who were helping me. I had a lot of friends who were calling me and checking on me and advising me. But at the end of the day, it's yourself who knows when you're not getting better and when you need help. And by that, I mean that if you're not getting better, you need to make that decision that now I have to get up, I have to get the car keys, get in the car, and drive myself to an emergency room without anyone else in the car. But if you wait long enough where you're too sick to do that, then you're going to need help from your family. And that means exposing your family to the disease also. And if you wait even longer, that your family has to call for an ambulance, then they're going to take you to a hospital which may not be very well equipped to deal with the situation. They may not have too many treatment options. And as a physician in the area for a long time, I got numerous calls from community members who had loved ones stuck in smaller hospitals, looking to see if I could help them transfer them to a bigger place. But that's not possible anymore. Everyone is overrun. Everyone has their own issues. No one is transferring patients from one hospital to another. So you want to give yourself the best chance. So you want to get there on time without causing unnecessary exposure to your family, and you want to be in the place where you want to be. And then besides that, I would say that there are other things that which you take for granted. You got to be prepared for those. You got to have Tylenol at home. That's something that I realized that we didn't have any. My wife is more strict than I am, following the expiry dates on it. So she had gotten rid of all of our medications. And then we found out that none of the pharmacies, none of the food stores, even gas station convenience stores did not carry any Tylenol anymore. And then I ended up calling some friends and getting some of their share from them. And other things like thermometer, bronchodilator if you're going to need one, a pulse oximeter, those things you're not going to find easily when you need them. So those things may be something that you can think of beforehand and have them ready. So there are a lot of resources that you don't think of till you actually get there. So that's something I think we need to be a little more prepared about.
You're right. You're very right. Very right. Fazil Hussain is asking a question. Anyone can take that. Would you recommend starting Tamiflu right away when you recognize that one has viral infection or upper respiratory tract infection?
Harun, I actually see that Dr. Sajid Chaudhary is still online. Let's
Sajid, you want to take that question?
Yeah, Dr. Sajid Chaudhary is online too. The question, Sajid, is about Tamiflu.
Tamiflu, should we, if you, on the appearance of symptoms, should one start taking them?
No, I don't think any Tamiflu has any role in this COVID infection. Initially, when we start getting the initial first cases, some people, they were using Tamiflu because as we suspect influenza, we start using Tamiflu in spite of the rapid antigen test negative in those patients. So some of the patients, they did get Tamiflu initially, but I did not see any role, and I don't think there is any role of Tamiflu.
Any antiviral? I mean,
there is antiviral. Actually, still is on trial. Remdesivir, which is initial results did show that it has some impact on the COVID-19 patients. But at this point, it's only being used in investigational trial on ventilated patients. So it's for mild to moderate symptoms, it's not being used at this point.
Thank you. Thank you. Next question is to Dr. Rasha Chodani. So provided that the vaccination is produced and we have the ability to do mass testing, how much time will it take after those two things that we will be able to return to our normal lives?
So first of all, let's do mass testing. I think mass testing is going to be available fairly quickly, and so that's going to be the first step in the situation. And that is something that's going to happen. But as far as vaccine is concerned, now I've spent most of my life as when I was a chief scientist for the U.S. Chemical Biological Defense Program, developing vaccines, drugs, therapeutics, and diagnostic devices for very, very bad pathogens. And our timeline was at least once we had an IND, that means that we were going to start human trials, was close to about 5 years. Now, because of all the emergency and trying to get things done much faster, FDA has kind of tightened that quite a bit, given some exemptions in terms of how many people you need to have in each arm, phase 1, phase 2, and phase 3. And has made some exemptions. Still, it will take 12 months to 18 months before we even have a vaccine. So please remember that having a vaccine in the newspaper, getting the first person getting vaccinated or getting in the study doesn't mean that we have a vaccine. We have to do we have to have volunteers for that. We've got to do 2 different arms of it. We've got to then figure out if there are any adverse effects in the small, a larger group, and a much larger group. And then after each of those groups, we have to take into account and take some time to appreciate if there were any adverse effects. So this is a long and lengthy process. Plus, please do not forget that no vaccine so far has been 100% efficacious. So even if we have a vaccine, It is not going to be that you get a vaccine and done. It's a done deal. The most important thing about vaccines is that once you have a vaccine, you have 60%, about 50% of the population that is now developing immunity because of the vaccine. You have a very, very good chance of developing herd immunity. And that is where we are today. So vaccines are not happening very soon. It will happen probably next year. By next year, meaning next year when we have the winter time again. Hopefully by that time we will have a vaccine. Now there are multiple studies that are going on in terms of antivirals and other therapeutics, and those are the studies that we are looking at very carefully, because the time period to produce that and then to come up with finished product, what we call a finished product, that means either the pill in a bottle or a vaccine in a vial. That is a much shorter period that is required for therapeutics. So that is where we are looking at to get some quick answers. And there is one antiviral that is being tested right now. There are 3 studies going on. No data is available right now. There's some anecdotal data that was done in a non-controlled type of a setup. But there seems to be some promise over there. But then we also have other medications, like what was mentioned, hydroxychloroquine, Z-Pak, etc., that in combination have shown in a very small number of people, by the way, very, very small number of people, to be efficacious, right? So, and plus they have a lot of side effects. So one of the things that, the folks that are in internal medicine and who see patients on a regular basis, I would like them to kind of tell the audience is, are you using these drugs, these emergency drugs, right? What I call the emergency drugs, in regular patients, or do you recommend using them just in patients who are in intensive care unit or in the hospital?
Okay. So we are running out of time, and we have several questions which people have posted on the Facebook, and they have started showing up. So if we can be brief, we will be able to answer a lot of questions. The question for Dr. Arif Mumtaz from Dr. Arif Muslim is, did you have any GI symptoms in the initial phase of your illness? There's another similar question. Did you treat yourself just symptoms, or did you take any medicine?
I did develop anosmia in the beginning, loss of taste. I'm not sure if that's a GI symptom or not, but the conventional GI symptoms, diarrhea and upset stomach, I developed with the hydroxychloroquine that I used. But just having said that, I had a colleague who was sick at the same time as I was. His symptoms were purely diarrhea along with high-grade fever. So he sat at home monitoring his systems and not doing anything with it, and he ended up coming to the hospital with acute renal failure. So his manifestation wasn't upper respiratory or lower respiratory, but was purely GI, actually. What was the second part?
Second part of the question was, did you treat yourselves just the symptoms, or was there any medication?
Yes. So I started with just treating the symptoms, but on day 3, I started having fevers also. So at that point, it was recommended by our ID specialist that if I wanted to start hydroxychloroquine and try and reduce the viral load, I should do that sooner than later. So I did try that. I took it for 6 days, and it was a decision made carefully, as I was considered low risk for side effects, and monitoring couldn't be done. And I'm not quite sure whether I got better because of that or despite that. But I did have hydroxychloroquine on board for 6 days.
Very good. This is question to Dr. Chodani. Dr. Nimra Jamshed posed a question saying, what epidemiological factors will need to be considered as we gradually go back to seeing patients?
So the epidemiological factor that we've got to see is the number of cases dropping down to a certain level. And once we start seeing that, then we can go back to normal in many ways. It is affecting everybody in an adverse way. But that's how it's going to be. I think the 14-day cycle that the administration has proposed is a pretty decent cycle. So in phase 1, you have 14 days to see if things are going down. And once you see that, you open up a little bit, and then another 14 days, you observe the epidemiology in terms of the disease, in terms of the number of cases, and then you start decreasing the burden and opening up a little bit more. So it will take anywhere between 14 days for some people, to about, I would say, 42 days for other people to get almost back to normal. We'll never be back to normal till we have a vaccine and an effective treatment for this disease.
Okay. We have another question by Dr. Atif Qureshi. I think, Sajid, you can take this question. Role of plasma exchange, not plasma infusion, but plasma exchange. Sajid Chaudhry? We can't hear you. Can you unmute
Yes,
yourself?
there is no role of plasma exchange at this point. Though, as he mentioned, the convalescent plasma use is going under trial also, as the other modalities, remdesivir, is undergoing. So, plasma exchange, I have not heard so far at this point.
Okay. Quick question, Rizwan Khalid. How does the virus affect the heart?
I'll be very brief. There are 3 or 4 ways in which the virus can affect the heart. One is what we have seen in the previous, this is a second SARS virus. In the first SARS virus and the MERS, Middle Eastern Respiratory Virus, both of them were also coronaviruses. There can be a direct effect on the heart. So it can cause a myocarditis. And they can present in fulminant myocarditis with hemodynamic compromise. That's one way how it affects. Number 2 is that the heart can be stressed due to a significant systemic disease. Like if a patient has multi-organ failure or sepsis, they may have increased levels of troponin or BNP. So that is not per se that the heart itself is the primary cause, but due to secondary effects, the heart gets involved. Number 3 is the patients that have coexisting COVID-19 and an acute coronary syndrome. So these are the 3 major manifestations. There are others as well. I've seen a 42-year-old lady who presented with fulminant arrhythmias. She was having atrial flutter, then she went into ventricular tachycardia. So they can present with significant arrhythmias as well. And I'll briefly mention in 10 seconds that patients with COVID-19 that do develop increased BNP and increased troponins, they do worse than patients that do not develop increased BNP or troponin. You look at all the studies, they do worse respiratory symptoms, their mortality is higher, their length of intubation is higher. So that's a bad sign. A cardiac involvement is a bad sign in COVID-19 ARDS.
I just want to add one thing in addition to what Rizwan mentioned, is that we have noticed that all these coronavirus patients, they are hypercoagulable. And that's why you were seeing D dimers are high. And I personally have done 3 or 4 acute MIs where there is no significant lesion, but significant clot or thrombus in the vessel. So that's why if you see that acute MIs are like less now in coronavirus period, but when they are usually because there is a clot in the arteries. Is Rizwan, that's your experience?
Absolutely. And we have started using full dose IV heparin, and there are certain centers that just start Eliquis and Xarelto from the get-go. I 100% agree with you.
Actually, that leads to our next question. Sadaf Osaf is asking, what are the recommendation of therapeutic anticoagulation, which you have answered that. This is going to be the last question to Dr. Rashid Utani. What is the utility of serum antibodies test?
So, a very good question. The utility of serum antibody tests. So, one of the things that we have to understand, the PCR, RT-PCR, essentially what it does, it gives you what I call, if you have been, if you have the disease, if you have the virus in you right now, it will tell you that. The antibody test will tell you if you have been exposed, you don't have symptoms. If you've been exposed and you might have had some symptoms, and if you're exposed and now you are potentially developing immunity. So it has a very important role in this particular equation because it is a very quick test. It's a very inexpensive quick test. takes about 10 minutes to get the answer. And then you can follow those patients. First of all, if somebody is IgM and IgG negative, you can tell them, and again, there's a weakness that the first 7 days, it will not pick up the answer. That's where the PCR utility comes in, and it will pick up the answer. But after 7 days of exposure, you can say with some confidence, and the sensitivity and specificity is pretty high on these things. You can say that you have not been exposed to the disease, so you got to be very careful now, because you have an opportunity to catch the disease, and you don't want to do that. Now, if the IgM is positive, that means that they've had recent exposure to the disease. And if the IgG is positive, that means that they've had exposure 3 to 5 weeks prior to getting tested. Now, if the IgM is negative and IgG is positive, then at that particular time, they have developed antibodies in their bodies to protect themselves, and they're immune. We don't know, again, we do not know if the immunity, how long does the immunity last? We are not sure, but it gives us some answer. And this is the way that we can essentially help open the nation, if we can do these mass testings across the board, and then have people go back to work.
Thank you very much. We have several more questions, and the questions are still pouring in, but unfortunately we are out of time. I would like to thank everyone, our panelists, Dr. Rashid Jazani, Dr. Rizwan Khalid, Dr. Arif Mumtaz, and our guests, Dr. Asif Rahman, Dr. Sajid Chaudhry, Dr. Aisha Zafar. Thank you very much. We will see you all next Sunday at 5 p.m. I just wanted to remind you all that we are going to have a telethon on April 26, 5 to 7 p.m. on TV1, channel TV1. And we would love to see you all coming over there and donating whatever you can. This is a fight we must fight, and this is a fight we need to continue fighting. Until then, good night. Thank you very much.
Thank you.
Thank you.
Stay safe.